All right. Alrighty, guys. So today we are going to how well do you know Disney? So I think I have
Boy, I
10
haven't had a
questions
Disney
here.
kid.
You're not a Disney kid?
I said I haven't had a Disney kid, and my grandkids live in California, so.
Oh, well, may the force be with you. I think there's 10 questions on here and we will go. I'll spend a couple seconds on each one. You guys come up with the best thing you can come up with and then we'll go through the answers, okay?
Are we typing
We're
our answers
typing in the chat, right?
Is that what y'all do with Dr. Ross when she does it?
Yeah.
Okay.
Do
sounds
your
good.
own rules. If you want us to shout it out, we can shout it out too.
Right, we just asking what you want us to do.
No, well, I just want to, keep it to the same as what you're used to. So,
Okay.
so I'll put my little chat over here. Hopefully it won't get in the way of seeing anything. All right, y'all ready? All right, here we go. What was the name of Bambi's best friend?
Oh Lord.
I should have some fun Disney music playing in the background. I didn't think
First of all, Nikia probably just watched that movie yesterday. She had 2 girls. That is not fair. I'm just saying.
First off, I have
I'm just
not watched
putting it
Bambi
out.
in 17 years, but I have a tattoo of Bambi.
Bambi is like one of the first cartoons.
Do you know how old I'm probably the oldest one in this class.
It was around then.
Around when?
Quick Google search. When was Bambi made? Let us find out.
Yasmin said the skunk. I'm dead.
1942.
No, that was at
1942. That's what.
Okay, so I should know that. That's my mama age.
Wow.
When my mama was 3 or something.
Oh my Lord. I wasn't allowed. But wait a minute, Miss White. You got children, don't you? You got these kids in here
crazy.
and they don't know who Bambi is?
I don't remember Bambi. I mean, you hear about it, but I didn't watch it like that.
I'm almost disappointed, ma'am. I'm almost.
Yes,
We all millennials on here, so you know.
My baby movies are like Frozen and Moana.
You got to take them back to
And
the old
Blippi
times.
or something, right? Who like Blippi?
Like who?
Blippi or Blimpy or something like that.
Girl.
All right. Next question, guys. Who was Captain Hook's sidekick?
Sidekick.
I didn't even watch Captain Hook.
Oh my goodness. What are y'all doing? The monkey.
I'm thinking about the Pirates of the Caribbean.
I know Captain Hook's sidekick.
Oh no.
The fat guy?
Got his name, but he's fat and he got glasses.
Oh yeah.
Nobody's got to answer for me. Oh my goodness.
Nurse Duhan.
Who said my name? Yes. Who said what?
Oh, this is Emerald. This is not. Yes. I barely watch Disney.
No, man, that's not.
I can leave my answer in the comments if anybody wants to know.
I barely watch Disney. I was not.
It's Mr. Simi.
I blame the parents.
Movies.
Now, ask me a word out the dictionary. That's all I was allowed to read.
Oh my goodness.
I'm a Cinderella kind of child.
We watch Disney like crazy, and
which popular song was sung by the genie?
See.
What?
Which popular song was sung by the genie?
Oh.
Let's see.
Let me see. I'm gonna time y'all. You got 15 seconds to answer these questions. Where's my timer? Oh, it's only 2 people answered so far. Come on, guys. You can do it. Oh, goodness. Come on now, y'all.
Have y'all been to Disney?
No.
I have been to Disney Springs. I haven't been to Disney World.
I've been to Disney World.
I think
Disney
it's a
Springs is
little
the
overrated.
is the boardwalk, like Kima.
Yeah, I've been to Disney Springs also. We stayed in a hotel real close to it.
Hmm.
All right.
We went last year in June.
Next one. What was the bird in the Lion King named? If any of y'all don't know this, then I'm gonna need y'all to exit stage left.
Sorry.
Y'all got 15 seconds on this one. This is, y'all get this
Oh, I
wrong.
said saxophone. Oh my
Saxophone.
God. Autocorrect.
Mine wants to say kazoo, and it's Zazu.
It was autocorrect. Sorry, let's do hot.
The time is up. Time is up. Who did the voice of Hades in Hercules?
Oh, Lord.
Girl.
I don't know. I'm about to ask
it
the
is.
review.
Let's do how you doing behind the scenes and everything. Don't nobody care about that.
First of all, yes, we do.
I'm typing and it's not typing. Oh.
Who? Nakia, who was the voice of Hades or what?
Boom. Miss
Well,
Johnson,
Lovely knew.
I
We
feel
can be
like love be
friends.
cheating.
I thought,
I feel like Miss Johnson and I could be friends.
I had a Cheeto, okay?
All right.
I don't
Anybody
cheat.
else? Anybody else got an answer for that one?
I don't
Alright.
know.
That's a tough one. Tough one. Which prince did Ariel fall in love with?
What?
Derek.
I put, sorry,
Derek.
wrong princess.
Oh, Jesus,
Wrong
Lord
princess,
have
my bad.
Oh, what y'all say? Whatever y'all say, that's what I'm going with.
Whoops.
My bad, I was close. You was close, Miss Hawthorne. You was close.
Ask me who was on Sex in the City.
What?
That's my
That is
question.
not Disney Channel.
That is absolutely not the Disney Channel. Oh my goodness. All right. What is Mr. Incredible's alter ego?
Am I really doing it? Stop.
Ooh, it
that
got real
is his
quiet.
alter ego. What do you mean?
I don't know.
Mr. Incredible's alter ego is Mr. Incredible.
Let's look at Miss Johnson.
That's not his alter ego. That's his real life.
Okay, but then what's his real life name then?
Okay, we'll do that then.
But now y'all just cheat.
The alter ego is the other person that you play. Like, my real name is Lovely, but my alter ego is Asia.
I don't know why Lovely is such
Hard
a
is his
pretty
real
name.
name, though.
I don't have an
He
alter ego
played
yet. I need to
Mr.
get one.
Incredible.
I need to get me an alter ego.
You know,
This is,
you married and don't have an alter ego?
Asia,
Ooh.
Lovely.
I am a major Miss Incredible fan. Incredibles, period.
I say, what happened when you turned to Asia?
You don't need to know that.
Oh,
we don't want Asia to come out.
What did you say, Renisha?
What was the piggy bank in
I
the
just
Toy
want to-
Story's name?
What causes her to come to the surface? That's my question.
You will never find out.
What?
What was the name of the piggy bank in Toy Story?
oh my God. Why? It's sent to just one person. Jesus Christ.
Very good, very good.
Oh,
Piggy.
yeah, I guess so.
Aunt Porky, Ham,
Oh.
okay. Hammy, Piggy, Ham, okay. Who's right? Stay tuned on when we find out the right answer. All right. What are the names of Donald Duck's nephews?
And I don't know.
This is my favorite cartoon before I went to school when I was little. My favorite.
All right, name one of them.
I would
I'm
not.
gonna
This
name
is,
all
I
three.
know the answer.
I
I
don't
know.
know it. I don't remember.
Boom. I'm telling you, that's the answer.
Oh, yeah.
Oh.
With they
The
bad
ducklings?
self.
The ducklings.
Oh,
I told y'all
Darkwing
I
Duck
love
was the
Mickey
bomb, but that
Mouse.
is not their names. I did enjoy Darkwing Duck as well.
I love Mickey Mouse.
Very good, very good.
Who said
I
really?
know
Who is Hazy Dizio? Zizo? Huh?
Really, Tiff?
I'm
Oh, that
just,
wasn't Tiff. I'm sorry. I thought that was Tiffany that typed it in.
All right.
Mm-mm.
Final question, guys. Let's see who's going to get it right. Donald Duck served in which branch of the military?
That's funny.
Think about what he was wearing.
Oh, he always had
Oh,
a
oh
suit
yeah,
on.
yeah, yeah, yeah.
Yeah.
Miss Ralph put 2 answers in. She said, I didn't know. And then she gave us another one.
Well, that's only because when you said think about what he was wearing, I was like,
you gotta go with your first answer.
oh, I don't give a damn.
We go, we go with the first answer. All right, let's find out what the answers to our questions are. Who's ready?
All right, ready.
Oh, well, normally we'd be in class, you'd write your answers down, and then we'd switch papers. So moving on. Bambi's best friend, his name was Thumper.
I have a tattoo of Thumper.
That's the bunny. Yep.
Mm-hmm. Fun fact, my basset hound sounds like Thumper, and I should have named her Thumper, but I did not.
Yeah, I barely watched Bambi. I watched Bambi probably like twice.
All right, Miss White, I expect for your homework this weekend, you take the children and you guys will watch Bambi.
I cried during Bambi like 2 times.
Who was Captain Hook's sidekick?
Oh, that's Captain
Right.
Hook.
I told y'all he was fat with glasses.
I
Yes.
used to just watch stuff and not even know the name of it.
Sorry, guys. I went too fast. His name was Smeed. Popular song by the Genie, Never Had a Friend Like Me. Strong work. I think most of y'all got that one right.
I got it right.
Yay. Also, putting in a plug, the new Aladdin with Will Smith was fantastic. I was
I
scared.
loved
It
it.
was. I loved it.
Yep, I
It was
loved
all
it.
right.
That's the only remake that they actually did that I didn't mind.
Absolutely.
Like it was pretty
It was
good.
very good.
Yeah.
All right. The Bird and the Lion King. Everybody got it right. Zazu.
Ooh.
Ooh.
Except for
And you know
somebody
why I
said
remember?
saxophone.
Because
That was Miss
when he gets onto
Ellaby, I
him,
think.
he yells his name.
What I did,
He said
Saxophone.
Yeah, the
saxophone.
man name was
that was on accident. It was autocorrect. I corrected myself and said Zazu.
I'm only
Don't
messing
do
with
me.
you. The voice of Hades. I think Miss Johnson was the only one that got this right. James Wood.
That wasn't a fair question, though. How you gonna ask us who plays him?
Exactly.
I mean, it's a fair question.
No,
Right or
it's
wrong? Who did RBL fall in love with? Prince Eric.
yeah.
Not Derek. Not Derek. That might have been a different version of the Little Mermaid, but it was Prince Eric. Who said Bob Parr for Mr.
Thank you,
Incredible?
Miss
I
Ralph.
did.
I said it. I said
It's Robert Parr. That's his real name.
Well, Nakia, that's not his alter ego.
Right,
It
because
is
his alter
Bob
ego is
Parr.
Mr. Incredible.
The Piggy Bank Ham.
Damn.
Yay! Not
That's like a
Piggy or
typical
Porky.
name because he's Piggy,
He's Pig,
a pig.
but his name is Ham. Donald Duck's nephews, Huey, Louie, and Dewey.
That's right. I remember.
Strong
that.
work. And final question, Donald Duck was in the Navy. Very good. All right. Now that we're all awake and we all remember what Disney things we need to go back and watch or review with the family and friends, we can move on with our lecture for today. I know you're excited. This is great. All right. So we're going to go into foot and nail care. I think we started yesterday talking about our patients and caring for their feet and nails. So I know that we talked a little bit. So what did we say about foot and nail care when it comes to our diabetic patients?
we gonna do it.
Don't clip them.
We don't clip their nails, correct? And we should do what? Inspect their feet very thoroughly.
Oh yeah. You said
Making sure
nails.
we're checking in between the toes, making sure we're checking for any redness, any swelling, any pain.
Any smell,
eh.
which means fungus, right?
I mean, it could just mean they have dirty feet.
Yeah, that part.
So we want to make sure we're checking out our diabetics' feet, especially because Sometimes they lose sensation in their feet, and it may be very difficult for them to know if they've stepped on something or if there's some sort of infection there. So it's very important that we know to inspect their feet, and that we're telling our CNAs also to inspect their feet.
Ooh, my bad.
We also need to make sure that we're telling our CNAs to not trim our patients' nails unless it is permitted by the agency or the healthcare provider has ordered it okay to do so. For most of our diabetic patients or those who have circulatory problems, we're not going to be clipping their toenails. Or I guess faux nails would be right, because I guess that's a thing now. People are putting fake nails on their toes.
Yeah.
I don't understand it, but
Let's do her.
yes.
Because they got
I have
ugly
a question.
Yes, ma'am.
Okay, so you know how some diabetics some are worse than others, and you know how like their feet or their legs start looking real disgusting, like tree bark and stuff like that. Okay, so with the facility I work at, we have more than 2 diabetics and their feet looks like that. So the one I had yesterday, his feet, like his legs and feet was like gushing, like from, like it was like open wound, and it was like gushing the like the little white stuff and all that stuff like that. Like why did the nurse that he had didn't cover it up or nothing. It was just out, and it was just messed up the whole bed sheets and everything. So it's like, are they supposed to wrap that, like clean it and wrap it, or are they supposed to just let it be how it is?
It depends on what the doctor order says.
Oh, see, I don't know all of
that. And feel free, like, especially if you guys who are working, if you see something happening like that, feel free to ask your nurse. Like, make sure that they know that you're not coming to them some type of way. Like, don't go to them, I see you got this foot open, it's draining everywhere. Aren't you going to cover it or something? Don't do that. But just ask them, because, if they know you're in nursing school, they'll tell you.
Listen, I'm not about to keep coming in here changing bed sheets because these things is gushing out everywhere. Like, I was like, are you going to wrap it, or you just going to let it breathe, or like what?
Yeah, they may have an order for him to keep it open to air. I don't know.
Yeah, because
it just depends on what the orders say. But of course, if the nurse is unaware of something like that going on, make sure that you would let her know. So, and you would expect the same from your CNAs whenever you guys start to work as nurses. Your CNA should be reporting any breaks in skin, any numbness, swelling, or pain on their feet. And they should also make sure that they're positioning their patients in a way that they won't get skin breakdown. Okay, so elevate their feet off the bed, make sure we're turning the patients every 2 hours as needed. Okay. All right, so if we're doing feet and nail care, what kind of equipment do we need? We're gonna need some wash basins, emesis basins, not for in case the patient is going to vomit, but because you can soak their fingernails in it. Please make sure it has not been used. You'll need a washcloth and towel. If you need nail clippers, you'll need them, if it's so ordered. You may need a nail or a cuticle brush. I haven't seen any of these plastic applicator sticks or the cuticle sticks, I'm talking about the little orange sticks that they use. I've not seen those in facilities, so I don't know that they still have them.
What is it?
The little stick that you use to help clean under your nails. It's got like a point on one end, and then like
we still have them, but they're wood.
I was just going to say it might be wood.
An emery board or nail file. Body lotion, please have lotion so that you can care properly for your patient's feet and skin, so that when you take their socks off, you're not inundated with a cloud of dead skin. Have a disposable mat if you can. If not, it's okay. And make sure you have clean gloves. Right? These are not your feet that you're dealing with, they're someone else's. Right? First thing we do, we all know we're going to identify our patient. Make sure if you have nail clippers that you have verified your order that you are allowed to clip the nails. All right, that's very important. Some places, in some of the long-term care facilities, well, some that I've been to anyway, I can't say that all of them are like this. Some have little nail salons in there. Some have or if they don't have a nail salon, they'll have a person who comes in and they'll actually go room to room and do their residents' nails and or toes if it's okay for them to have that done. So it depends on the facility you're at. If, you know, sometimes the real ritzy ones have those services. Sometimes family members like to do it as well. So just check and see, you know, who's doing what and what's ordered before you get started. Make sure it's a safe environment. Find out if there's any certain problems with your patient's feet. Find out if they, you know, have any home remedies, like they, you know, usually cut their corns, or they use razor blades to cut things off of their feet, or, you know, find out what they, yeah, I know, it sounds.
I don't use them. I don't even let them use them on my feet. They mess your texture up on your feet.
Yes. So just find out, you know, what they typically do about their own foot care, if they can let you know. Find out what kind of footwear they usually wear. You know, heaven forbid if my child's ever in a hospital somewhere, even when she gets older, she does not like to wear shoes. I mean, she'll put them on when we're going places, of course, but when we're home, shoes are a thing of the past. She'll go outside, she'll everything. And I'm like, I don't understand it. I just don't. But anyways, so, you know, find out what kind of shoes your patient typically wears. If it's flip-flops, or if it's tennis shoes, or if it's, you know, maybe you got your little patient, Miss Sylvia over here. She might be 90, but she still wears her stilettos. You never know. All right. So find out what kind of shoes they wear so that you can kind of, you know, judge what you're doing with their feet, or see why their feet are in the condition that they're in. Right. See if they're at risk for any foot or nail problems. History of diabetes, if they had any strokes, if they have any circulatory problems, right? And then, of course, you're going to do your hand hygiene and inspect all surfaces of toes, feet, nails. Make sure you get in between the toes as well, to see what's going on in there, okay? This is the fun part of our job, guys. I'm being facetious, right? Make sure you can palpate while you're doing your foot and nail care. This is a great time to, again, assess the areas. So you can assess those pulses. You can compare the strength of the pulses, note the color and warmth of your toes and feet. Check that refill. So this is just an opportunity for you to do some further assessment on your patient, all right? And also, like we said yesterday, with your care for, when you're caring for your patient, make sure that you ask them if they can do it themselves, or how much they can do for themselves. You know, maybe she doesn't have the dexterity to paint her toenails, but she could put her lotion on her feet, right? So maybe have her, you know, if you can do the lotion, I'll paint your toenails, and then you put your lotion on your feet, or however you want to do it, just to keep her involved and as independent as she can. Or he, you know, some people, some guys like their toes painted as well. So whichever floats their boat, that's what you do. Make sure you have provided some privacy for your patient. You know, everybody might not like their feet, and they may not want everybody to see their feet. So make sure, even though we think, oh, it's just feet, you know, we go to the nail salon and everybody's looking at our feet all the time. Everybody doesn't like that. Everybody doesn't do that. So make sure you give them privacy as well. When you get ready to soak their feet and fingers, I would say if you're going to start with the hands, go ahead and start soaking the feet. All right. Remember, we are not soaking the feet of patients who are diabetic and those who have compromised circulatory system. Okay. We don't want their skin to be submerged in that water for a long period of time. But if it's just, you know, your patient has no other health problems, no other concerns, I would soak the feet while you're working on the fingers. And mind you, this isn't going to be like that 3-hour mani-pedi. This is just something quick that you're going to do at the bedside. So I would put their feet in the water, make sure it's nice and warm, not too hot, not too cold, and put their feet in there. And then I would go on and do the hands, right? So if they are confined to the bed, let's just say they're not allowed to sit up or get out of bed, then you could have them bend their legs, put the feet in the water while you're working on the hands. So you can adapt to whatever your patient has to do. Okay. All right. So then you're going to go ahead and you're going to soak for about 5 to 10 minutes. you'll clean their nails while immersing their fingers, and you see she's got the orange stick here. She's making sure she's cleaning up underneath the fingernails, so that she can get them nice and clean. Use a nail brush if you have one to clean around those cuticles. Like I said, sometimes you might have that occasional patient who likes to go dumpster diving. Not the dumpster diving to get gifts like, Bath and Body Works and things that the mall stores have thrown out, but dumpster diving as in they found their diaper and there may be some poo there and they've gone and played in it with their hands. So
and then they spread it all over the wall.
All over the walls, all over the floors, all over the, it's a thing, guys. I'm sorry. It's rude awakening into nursing. And just because you are a LVN does not mean it absolves you from cleaning any of the mess. That's not what that means at all. You can have help, but if you find a patient like that as an LVN and they've painted the walls, as we like to call it, it is not your duty to walk off and act like you didn't see it. All right. You got to get your hands dirty. Ask me, I've seen it before. I actually made an enemy. Well, she's a friend now, but I made an enemy her first probably several months of working. We had a patient and he had an ostomy bag. He was 2. He took it off and, flung it around the room and played in it, all the things. And she thought that someone else was going to come clean up the mess. And she walked out of the room and his door was open so I could smell what was going on. And I peeked my head in there. I'm like, wait a minute. Just because we're RNs doesn't mean that we don't have to do this. So I'm gonna need you to get some cleaning materials and I will help you clean this up. She didn't like
Somebody
that.
needs to have a one-on-one conversation with the nurses in my building.
Say what now?
I said somebody need to have a one-on-one conversation with the nurses at my building because they swear because they're nurses they don't have to do it.
No ma'am, that is not the thing. And especially if if it's your patient, then you are responsible for the care of that patient. So I understand sometimes we have other things that we need to get to. Of course, if I'm in the middle of performing CPR, then I can't do, I can't change a brief at that moment, right? But if I'm not doing anything else and there's poo everywhere and that is my patient, I got to get my hands dirty. Like there's no way around it.
Leave that patient sitting right there. And I could be sitting outside. They're going to leave that patient there, come all the way outside to get me and have me go do it.
No, guys.
Yes, they do that at my job too. It's so aggravating.
That is
like I said,
like you're right there.
Yeah, that's true. They do that.
Sometimes that does happen because they may have other things to do, may have other meds to give, may have other procedures to perform. I'm just playing devil's advocate. Playing devil's advocate, not saying.
With lazy nurses, they don't do anything. When they're done doing what they're doing, they just sit there. They'll eat, they'll talk to other people and stuff like that. But if we really have stuff to do, like we give baths every day of the week except for Sunday. So if we're doing baths and stuff, they will make us stop doing what we're doing, where they're not doing anything to make us go on the other side of the facility, far from what we're doing. That's not even as important as what we got to do something that they could have did.
Thank you. And half the time they'll walk past the call lights and everything. You go in the room to answer the call light and guess who they want? The nurse.
Yep. So let that be y'all's lesson, when you become the nurse, then you set the standard for how you think this should go, right? We shouldn't be walking
trust me, I
people.
am. That's the reason why I started from the bottom and I'm working my way up. Because I feel like you can appreciate your aides more if you know what they're going through.
Absolutely. I mean, it's hard work. It's hard work.
That's management, period.
And so, I absolutely appreciate my CNAs when I have them because where I've worked, many places, we have not had CNAs at all. We have been nurse, CNA, dietary, everything, RT, everything. So I've been there. I know that it's a lot of work, and I know that when I do get a CNA, I need to appreciate them. So that means I need to help you do your job. I will help you. If I'm in a patient's room and they've soiled the bed, then I'm already in the room. Why would I not change them? You know what I mean? So, kind of think about these things as you go through your nursing career. All right, anyway, back to foot and nail care. So make sure that, you know, you're soaking your patient's nails because you may have some dried materials there that you may need to get out. So soaking them before you try to clean them off will help it come off a little easier. And this is just a cute little picture here showing you the correct way to clip the nails. This is not the nail salon. You don't need to worry. You don't need to ask your patient, do you want square round or do you want just round? Or, you know, what do you want? You want pointy nails? That's not what we're doing. We're just making sure that they're not going to scratch all their skin off with their fingernails being too long. So you're gonna cut straight across, all right? Straight across. All right. Once you're done with your fingers and your hands, then you can start over going to the feet. You're gonna start on any callus areas. Now be very careful because you don't know how long those areas have been calloused. And my job is not to make you have pretty feet. I'm just making sure your feet are not in terrible condition. All right, so we're not doing like they do at the nail salon and getting the file and, you know, scraping and getting all the calluses off and doing all the things. That's not what we're doing. We're just making sure that their feet are in working order. Okay? Make sure you go in between the toes. Make sure you, once you're done, that you dry those feet in between the toes thoroughly, okay? Once you're done, please put some lotion on your patient's hands and feet because dry skin can end up making breaks in the skin, which would be your first line of defense to infection. And if there's open breaks in the skin, then your patient can get an infection easier. So that's why we want to make sure that we keep their skin moisturized. Also, because we don't want that plume of dead skin flying off of their feet when we take their socks off.
I'm sorry. Let's do her.
Yes.
They said, I was told like when we do lotion and moisturize our patient's skin, never put the lotion between their toes.
That is correct. That is correct,
Okay.
because
So
that could keep it, remember, like your toes, they're kind of close together, right? So that's going to be like a breathing ground if you have any moisture that's still there in between the toes. Cause infection.
Okay, I was like, I don't do that because that's what they told me, but I was just making sure because, you know, everybody say something different.
And then you're going to make sure your patient is nice and comfy. If she wants her nails or toes painted, you can paint her nails or toes with whatever color she's got if you have the time to do so. With our PD patients, especially our cancer patients, we would always paint their nails and toes to make them feel better. Just because we had one male nurse, he used to paint his along with the patients because it was fun for them. So he would do it, you know, just to brighten their day. So just, you know, if you have the time, it always matters to the patient that you took the time to do something like that for them. So once you're done, please make sure you wash out the equipment that you have used. Please dispose of anything that is disposable, and then do hand hygiene, all right? When you're done, if you can, if your patient gets up to walk off, make sure you're watching how they're walking, because if they walk a little funky, it might mean that maybe something is hurting them with their feet, especially if they weren't, you know, hobbling along before. All right. All right, moving along to hair care and things. Do you guys typically do hair care when you're working?
Yes.
So what do you guys usually do?
I mean, as far as we can wash their hair when they're in the showers, or if they don't want their hair washed, or if you're just getting them up for the day, you brush their hair, you put it up. Some of them don't want you to touch their hair. It just depends on the patient.
Okay, very good. And they have the right to refuse, absolutely. In the same way that some of our patients or some of our facilities have that little lady coming around to do manicures or pedicures, sometimes the facilities that you're working in, you may notice they may have a little beauty shop. And it's the cutest little thing because beauty shop day will be on a certain day and they come in and everybody's so excited. The little old ladies get their hair did and they just feel like themselves for a day or two.
I was just telling Nakia and them last night how my residents are like extremely happy right now because they haven't had the beauty shop open since February.
Oh, goodness.
And so now it's open and they're giving out free haircuts for a month.
Oh, that is so
And they're
awesome.
like extremely happy because they're starting to feel like themselves again.
It's so important. I'm telling you, when you're in the hospital, or if you're in a facility, sometimes you just don't feel right because, you can't bathe when you want to. You can't do what you like. You may not have the strength, or you may have IVs in your arms and you can't do your hair. And it's just those little things that make you feel a little bit better, right? You may still be sick. You may not feel 100%, but just doing those little things help people so much. So, I mean, that is fantastic that they've gotten there. Oh, that's so sweet. I'd love to hear that. Like it says here on your slide, it helps them with their sense of well-being, right? Whenever you're talking about combing, shampooing, any of those things, getting their hair did. Us ladies, we go through our entire lives getting our hair did, right? We may not be, doing all the things to it, but, going to the salon is always a treat. Someone massaging your scalp while they're washing your hair. It's just someone else doing your hair that you don't have to do it. And then it always looks great at the end, unless you, go to the wrong hairstylist, right? So just imagine, you get older, you're in a facility, and you don't have that option anymore. So this is a great thing, I'm not saying, us nurses should be hairstylists as well, but, we can at least take the time to try and help our patients feel a little bit better about themselves by helping them to groom. Just know whenever, let's just say your patient's confined to the bed, it can be very hard to manage their hair. And that does not mean that we just leave them there and let their hair get tangled and matted and things like that. We need to make sure that we're providing care here as well. So comb it, brush it. I know a lot of times I'll see if we have a patient that can't really move around, then we'll braid their hair for them. Nothing elaborate, but just, a single braid, because that'll help it to not get as tangled as it could, right? All right, so let's get to that. All right, you can delegate this skill to your CNA. Make sure that if your patient has any sort of immobility problems, that your CNA knows how to work around that. All right, let's just say your patient can't move their head all the way to the left. They can't do like my mother used to do when I was little and turn my head to the side that she needed it to be on for her to brush that side of my hair. We don't do that. We need to make sure that our CNAs know how to position our patients so that we can properly do their hair without causing any further damage. Okay? Make sure they know what to look for lice. If you notice any crawly things in your patient's hair, please let me as your nurse know. That is very important because it is, for one, your patient should be on contact isolation if they have lice, and for two, we need to treat it. So being sure that we have our CNAs aware of what that may look like. Patients scratching their head excessively, any bites or nits around the hairline, behind the ears, we need to make sure that we're having them to monitor those things. Making sure to report back to us how the patient tolerated any procedure, right? Well, I was combing her hair after I shampooed it, and then she complained of some really bad neck pain. Okay, so then maybe we'll have to shorten the time that we spend doing hair, or maybe we need to figure out a different position to put our patient in when we're caring for hair, things like that, right? And then also, your CNA should know if your patient is having any kind of bleeding problems. If they're on anticoagulants, things to help them clot a little more, then we need to know, your CNA needs to know, all right? Because they should not be using things like straight razors. They should be using electric razors instead when it comes to shaving your patient, right? When it comes to shampooing, combing, shaving, all those things, you're going to need the typical equipment that you would need for providing any of those services. A wide tooth comb works best, especially on wet hair. You're going to need a hairbrush.
Hey, my daddy said, can he give you the card on the phone?
So I can do a text link, and I can have them pay it over the phone that way, but I can't take payment.
Miss Ellaby,
Okay.
You can do it online.
can you mute yourself, please?
All right,
I think this is you. There we go. All right. Where was I? Hair care, white tooth comb, hairbrush. You'll need the patient's shampoo. If the patient does not come with their own shampoo and conditioner, then you'll use whatever the facility has to wash their hair. I know, well, from being in pediatric world, our shampoo is baby shampoo. Everybody uses baby shampoo, which is pretty neutral for most people across the board. So, but I don't know what other facilities and hospitals, I don't know what they typically use for that. You'll need a water pitcher with warm water. Make sure it's warm, not too hot, not too cold. You'll need a shampoo board. Do you guys have shampoo boards at your facilities?
I don't even know what a shampoo board is.
So it's like a board that kind of extends on the top of the, like on the bed, so that if your patient is bed bound, it's almost like having a sink under their head.
Nope, we just use the wash basin.
Yeah, I told you, I must be in some of these fancy places. Some places have them, some places don't. They work great if you're in a facility that has one. Because like I said, it's like having a sink when your patient is bedbound, so that you don't have to mess up the bed or anything like that when you're washing their hair. Make sure you can get you a waterproof pad to put there, so that in the event that they don't need their bedding changed, that you don't have to change it because you've gotten it soaked and wet. If your patient has lice, they're going to need some medicated shampoo. Like I said, if your CNA notices this, then they need to report it to the nurse, and then you need to report it to either your charge nurse or to the physician, so that we can get that taken care of. The doctor will order the medicated shampoo, and then you will use it as ordered. All right. And then disposable shampoo. They also have nowadays that what's it called? Is it the dry shampoo that you can use? And that works pretty good too, but it doesn't replace soap and water in my personal opinion. But it works in the event that you know, patient just needs a quick something or other. All right. If you're shaving your patient, make sure that you have either a new disposable razor or the patient's own electric razor. If they have bleeding tendencies, you want to always use electric razors. Make sure you have your gloves, aftershave, shaving cream, if the patient wants it and they're allowed to have it. I've not done mustache care because I do not think anybody wants me near their mustache with scissors. So I mean, I haven't been in a situation where I've needed to do that, so I cannot say how mustache care would go for anyone, but especially nowadays when, you know, having a really well-groomed mustache and beard are the thing. I don't know how they would maintain this in the hospital setting. But if you have to, scissors, a brush or comb, bath towel, and I don't know where you're going to find a gooseneck lamp to provide said mustache care. So we'll just leave that out. All right, so first thing you're gonna do, like any other procedure that we do, we're gonna make sure we have the right patient, identify your patient, right? Hand hygiene, let the patient know what you're gonna be doing, and then you wanna make sure before you start actually doing the washing, the combing, the anything, inspect the condition of the hair and the scalp, all right? Make sure that there's no infestations present, okay? It's pretty important because you don't wanna start washing the hair and then see things falling out like that look like creatures, okay? You want to inspect first and then do the work, okay? Assess the patient's hair care and shaving preferences, right? You know, I don't know, you may have a patient who prefers to just condition their hair a couple of days a week and then do a wash every other day or 3 times a week or 2 times a week or once a week. So make sure that you're assessing your patient's hair care preferences before you start doing anything, okay? Assess if they have any product preferences. You know, if, you know, you're in a facility and all they have is baby shampoo and you say, oh no, I can't deal with that. I'll just have my significant other bring me whatever it is I need. Or now that we're in the age of Amazon, I'll just order my stuff on Amazon, and then when it comes, then we can do my hair. All right. Find out what the patient can do. Right? This is across the board, everything that you do, make sure that you find out what the patient is able to do for themselves before you go and do it themselves or go do it for them. So if Martha can hold her comb by herself and she's able to comb the front part of her hair on the right side, let her comb the right side of her hair by herself, all right? And then you do the rest if she can do the rest. But at least give her the opportunity to still feel somewhat normal and somewhat independent by letting her do as much as she can by herself, okay? Make sure that there's no contraindications to what it is that you're doing. Like I said, some of those people who have head injuries, neck injuries, may not be a good idea to manipulate their head to shampoo and do all the things. So you need to make sure you're checking with your orders, any policies to make sure that it's okay to do. Okay. And make sure the room is safe, the bed's locked if they're in the bed, everything's working properly, there's no spills so nobody falls. All right. Right. So we've already gotten our supplies. Put it all at the bedside, let the patient know what you're doing. Honestly, if you're trimming or doing any kind of mustache or beard care, I don't know that many men are going to actually allow that. They're very particular, especially younger ones. So I don't know, like, I don't know. Has anybody had to do beard care or mustache care on their patients? Are they, like, how do they respond?
You said beard care or what?
Beard or mustache care?
I mean, we wash it, and we're not the ones that actually trims it. They go to the beauty shop to get it trimmed.
Okay. That's what I was wondering. I couldn't remember ever doing beard or mustache care, so I just wanted to see what anybody else, in their facilities do. So very good. We can ship them off to the beauty salon and have them taken care of there. Fantastic. Okay, so if your patient is able, make sure that they're sitting up 45 to 90 degrees. All right. Whatever they can tolerate. Make sure that it's private. All right. I don't know about y'all, but if I'm getting my hair did, I would prefer being in a room by myself. That everybody doesn't see the before, I just want you to see the after. So make sure you give your patients privacy, okay? Make sure the lighting is good so that you can see what you need to see. So don't do your patient's hair in the dark. Don't try to trim anything in the dark. Don't try to shave them in the dark. Make sure you have good lighting. Okay. Right. If you're combing and brushing the hair, not shampooing, just combing and brushing, it's easier to start at the ends if your patient's hair is super tangled, right? So let's just say I've had a few patients who have been in car accidents, and obviously when you're in a car accident, hair care is not my priority, right? My priority is making sure that you're going to live and breathe and things like that. So then it might be a day before your hair gets combed, and your hair might be all matted up and everything. So lightly mist it with water, maybe put a little conditioner in there if you have it. If you have lotions, that works great. Like I said, I'm in a place where they do baby lotion, baby shampoo. So a little bit of that baby lotion is great in the hair just to help get it untangled before you comb it, because you don't want to cause your patient more pain, right? Use a wide tooth comb if you have it, and then, comb the hair. Shape it into whatever you want it, whatever the patient's asking for, if you can do it, and then you're good to go. We see here's our friend getting her hair combed. Putting it in sections will help you to comb it easier than just trying to do all of it at one time, right? Right? If you're shampooing your patient, for someone who is bedbound, if you have a shampoo board, and I have a picture of it next, so I'll show it to you guys. That makes it the easiest to do, a shampoo board. But you would put your waterproof pad under your patient's shoulders and head and neck, and that just makes it to where you don't have to change your sheets, you don't get water everywhere while you're doing this, right? Put the patient supine with their head and shoulders at the top edge of the bed. right? And then you're going to put that wash basin underneath that end, right? Make the patient comfortable. Brush and comb that hair before you start. It makes it less tangly. Anybody with curly hair knows that's one of the keys to not so terrible wash and dry episode is to make sure you comb and brush it before you wash it. So this is the shampoo basin. You see, it's just like being at the salon, except for you're still laying in the bed. So the head goes in there, we can wash it, we can pour all the water in there, and the water just drains off into the basin. So it's a great tool if you ever get to use one. I've not, I mean, you know, pediatrics, they're small enough typically that we can just pick them up if we're doing their hair washing. Otherwise, mom and dad usually do it, so we don't typically have to worry about it, right?
So when you have a baby, I've always asked the nurse if I could shower my baby. And they're
Yes.
like, technically we're not supposed to do that because I guess they're responsible if something happens. But the nurses have been nice enough to let me shower, but they're there like right next to me.
In the hospital setting?
Uh-huh.
NICU baby?
No, just regular.
Oh, no, listen, you want to shower your baby, that takes a load off of me. Here you go. Here's some supplies.
Yeah.
And I'll see you later.
And I figured, I don't know, I think it's just cute to give them their first bath. So I've always asked if I can do it. But they're like, we're not supposed to. We're supposed to do their bath, but
Oh wait, for the first bath?
yeah.
Oh, yeah, that may be a little different. I'm never present for the first bath. I'm talking about when they get older. No. Yeah, so for the first bath, they're probably and I'm just guessing because I'm not the nurse ever there when the baby's first born. They're probably doing an assessment as well.
I gotcha. Okay, yeah. Because I thought it was like just in case something happens to the baby while we're showering the baby, like I drop it.
No, there's a certain way that you need to do it because you don't want to scrub baby's, you know, skin to skin, and then for any anomalies that might be present when the baby is first born, you as mom may not really be trained to see what they would see because some things you just might not realize. If there's a little dimple on the back, that could signify something and you wouldn't realize. You'd just be like, oh, that's a cute little dimple on the back. So it could be that they're doing their assessment.
Normally, new moms or whatever, if you just had a baby, maybe because you're on medication also.
That too. We don't want you to drop the baby.
Right.
It's not a good look. All right, so go back to shampooing our friend here. So make sure, you know, the water is an appropriate temperature, and you can always have your patient stick their hand in the water to make sure it's the right temperature for them, right? Make sure it's completely wet. If the hair has matted blood in it, let's just say there was some sort of accident or something, you can put peroxide on it to help dissolve that blood in the clots, right? And just rinse it off with saline. That's also your tip for if you get blood on your scrubs. Peroxide is great. Saline is great. So that's just your little tip from Heloise. Right? Okay, we still got a couple minutes. Right, so when you shampoo your bedbound patient, you're just going to do the same thing that you would when you're regularly shampooing, except for since they're lying down, have your patient, and it was on the picture before, put something over their eyes to prevent them from getting shampoo or water in their eyes, right? Once you're done, just, you know, dry everything off and then comb and go, right? Any questions on shampooing our patient? I'm gonna take that as a no. Let's take a break, guys, and come back at 10:10. All right, everybody getting back and sign back into the chat.
The number you entered was
Make sure everybody's live on camera, please and thank you. And we will go ahead and get started. All right. So we talked about shampooing and conditioning and all the things for our patient's hair if they're bedbound. And we said we're going to get them all dried off and then we're done with them, right? All right. Yeah, we just said all these things, didn't we? All right. So comb your hair, comb your patient's hair, get any tangles out, dry it with a dryer if desired, or if you even have a dryer, dry them. I've seen most places it's just air dry. If the patient needs any products in their hair, please put it in there for them. And then once you're done, just leave your patient in a comfortable position. Clean all your supplies that are reusable. Store them wherever they're supposed to be stored. Remove your gloves, perform hand hygiene. And what's the last thing you're going to do once you do your hand hygiene?
Document.
Absolutely. Document it. Tell them what you did, how the patient tolerated it. All right. If you're shampooing your patient with a disposable shampoo product, so they have these things called shampoo caps. Have you guys ever seen these before? The shampoo is already in the little cap. You put the cap on the patient's head after you've heated it up. You massage the head, and then you take it off, throw it away. It's almost like a dry shampoo, except for it's in a cap. So your patient could be anywhere when you do this. They could be sitting on the bed. They could be lying down. It doesn't matter. Make sure, once again, you have on your clean gloves. Make sure you comb through any tangles or anything. Make sure you observe the scalp, assess it, and make sure that everything looks good. Then you're going to take that package, put it on their head, put the hair, make sure all the hair is up in there, and then massage it. Now, if you ever see any of these disposable products like this, typically the directions are on the package. So if you ever have a question of what to do, just look at the package. All right, because it will tell you on there. So you'll massage the head through the cap for about 2 to 4 minutes, and then you'll take it off, put it in the trash can, and then you'll, comb their hair, and then get your patient comfortable again. Okay. Here is a picture of our shower cap. Right. So, you'll notice that she's just massaging the product into the patient's hair, and then she'll remove it once she's done. Okay. All right, if you're shaving your patient, this could be any patient depending on what area of the hospital you're working in. If you're in a surgical area, of course, you may have to shave any kind of body part because they typically like for the area to be hair-free when they're going in for surgery. So you would have to, depending on where you work at, just monitor what they do and what you're required to do. So I believe most of us have shaved before. It's a little awkward shaving someone else. I will say that, but it has to be done sometimes. So if you're shaving your patient with a disposable razor blade, make sure that you're using some sort of shaving cream or something. Don't just, do a complete dry shave on them. That's more for patient's comfort. If you have a male nurse on your unit, honestly, I try to be their best friends because in situations like this, I'm not sure how to shave a man's face. So in this instance, I would try to find a male nurse or a male CNA that can shave the patient for me, okay? Not saying that I don't know how to shave anything, but it's different when it's a face and then when it's not your face, right? So So just make sure, you have a good understanding of what you're doing when you go to shave your patient's face, but please use some sort of shaving cream or something prior to shaving them, right? Once the facial hair is shaved, make sure you rinse their face thoroughly, get all that product off of there, and then dry and apply the aftershave if your patient wants, okay? If you're also, when you're shaving the patient, it doesn't say this here, but best practice would be to put a towel across their chest so that when you shave them, you're not making a mess everywhere. Typically, once you're all done shaving them, you pick the towel up, fold it up, put it in the excuse me, in a linen bag so that you can dispose of it. But that way you don't have hair everywhere, okay? If you're shaving them with an electric razor, make sure it is the patient's electric razor, right? And remember we said if your patient has any bleeding tendencies, you want to be sure to use an electric razor instead of a disposable razor, okay? And that is because if your patient has a tendency to bleed, if they're taking some sort of anticoagulants or some aspirin or something like that, and you use a regular disposable razor and you accidentally cut them, it's going to be hard for them to clot that off. They're going to have a hard time and they're just going to keep bleeding. So if your patient has a bleeding tendency or if they're taking any of those anticoagulants, you want to make sure that you're shaving them with an electric razor, okay? Put on whatever kind of skin conditioner or pre-shave, however they, your patient, whatever their regimen usually is. Turn the razor on and begin by shaving across the side of the face. Once you're done, turn it off, take off the towel, put on their aftershave lotion as, or whatever their regimen is, unless it's not allowed, okay? Mustache and beard care, same thing. Like I said, I would refer this to, if your facility has the beauty shop, I would refer this to them or to the patient's family member or to a male working in the facility that could possibly get this job correct and not butchered up like I would do, because I don't have high hopes for any kind of mustache or beard care for myself. If I have to have, a trim is involved, I would be frightened for the patient, okay? Make sure you put your patients back in comfortable positions once you're all done. Make sure the call light is within reach. Put anything reusable into its proper place. Make sure you've cleaned it first, and then put your soiled linen into the linen bag. Hand hygiene, and then what else? Document. Yay.
Document.
Very good, very good. All right. Let's see here. This is also the same as doing your patient's combing and shaving. We'll skip on this one. All right, this is a good question for you guys. A male nurse is preparing to shampoo the hair of an Amish woman. The woman refuses the nurse's assistance. What action should the nurse take? Should she A, explain to the woman that this is the only time the nurse has to help her? B, seek assistance from a female nurse to make the patient more at ease? C, enlist the help of the patient, or of the family members, giving them the supplies to complete the care? Or D, leave the patient alone. Eventually, she will need to cooperate with the male nurse.
I would do B.
I think B.
B?
B.
B. Very good. Very good. Why is that? Why is B your answer choice?
Because she doesn't want to have a male nurse help her, so obviously she wants a female nurse, and it's just the right thing to do.
Absolutely.
A part of their culture also that another man is not allowed to touch them.
Absolutely. That is, you hit the nail on the head right there, right? The Amish consider touching unrelated males and females kind of taboo. So make sure that, when you guys graduate, hold on just a second. I don't close this door. I'm sorry. I've got work going on in my house. So this is something that you guys will really get into when you're working through your concepts class. There's I know there's a nice piece that is focused on on providing culturally competent care. And part of that is to know that some cultures, like Ms. Kawana just said, they prefer female providing care for the female. So if there's a male nurse there, and you guys will see this when you start, probably sooner than you think, when you become charge nurses in your unit, that you'll have to make these kind of considerations whenever you're making your schedules and assignments for your nurses. So keep these things under consideration whenever you're providing care, that, you know, no, we're not just going to leave the patient alone. You know, male nurse, I mean, for certain things, you may just be able to say, okay, she needs her hair washed. She's not going to let Nurse Tim touch her. So nurse, let's see, nurse, who am I picking on today? Nurse, who have I not picked on? Nurse Tiffany is going to go in and do this patient's hair washing today, right? So it may be like a teamwork kind of effort like that, where yes, Nurse Tim's going to have this patient today. He can administer her meds and things like that. But when it comes to providing actual care for this patient, we may have to have Nurse Tiffany stop in and do those things. Okay. Very good. All right. Does anybody need to go over making an occupied bed? This was our skill from last week. I feel like this is one of those things that talking to you doesn't really do anything, because it's making a bed. And I feel like you've already learned the skill, so yeah, I'm not going to waste. Say what?
I was just confused about the part where you roll your patient over and you're putting your new sheets, right? At that moment, when you're gonna roll your patient back, do you take off your gloves and put clean ones on, or switch them out?
To like, pull the new?
Yeah. Like whenever you're gonna take off the old, you put that in your linen bag, and then you put on some new ones, roll her over, and put it. Is that just how? Okay.
That's absolutely correct.
Making sure.
Yes. Okay. Very good. Any other questions on bed making that I can answer for you guys? Either occupied or unoccupied. Practice your mitered corners at home. It's not required, but it's so pretty when you do it.
Yes.
I'm kidding.
Do we get an A for making mitered corners that look pretty?
Say what now?
Do we get an A for making mitered corners that look pretty?
No, but I'll put a note on your checkoff that says very pretty mitered corners. I can do that.
I like that.
Okay, very good. We'll stick with that then.
And she checked my corners. I remember.
I did.
Good for you.
When we were in school, once upon a time, that was one of the things that could fail you, is not doing the mitered corners. It wasn't an optional kind of deal. It was, your corners have to be mitered. End of story. So in that moment, I thanked my mother for making me do mitered corners from, like, I think I was like 6 or 7 when she taught me how to make a bed. And I had to do mitered corners.
Was your family military?
My mom was a nurse.
Okay.
So mitered corners. Everybody's got mitered corners. Let me see underneath your comforter. Oh, geez, Mom. Anyways, so I did want to point out these positions with bed making, or positioning your patient as kind of what it really is here, because you will see these terms or you'll hear them while you're going throughout your days. So have you guys talked about any of these terms so far in any other the other classes?
In A and P.
Yeah, in A and P.
The flat supine, Fowler's.
Okay, good. So we know Fowler's is when you've got the head of the bed raised to the angle of 45 degrees or more.
Yes.
Do you guys know how to tell what the degrees of your bed is?
No.
I will have to look on the beds at the campus, because I don't know if it's on there, but most of the beds have a little, it's almost like a leveler, like tools, doing things around the house, the the level thing. You know, you use it to hang up your pictures. The level with the little bubble. You know what I'm talking about? Okay, so there's one of those on the bed. And it will tell you, so if you're not sure and your doctor says, I need this bed to stay at 30 degrees, there's a little level underneath the bed or on the back of the bed. Some of them are pretty clear to see. Some of them are on the side rails that will tell you exactly what degree of angle your bed is. So I'll see if there's one on the bed on campus. I don't know if it's there or not, but I'll look and see because sometimes they are there. Fowler's, like we said, is 45 degrees or more. So you put your patient in Fowler's position if they're eating, right? If you're putting in an NG tube, if you're suctioning them. This position is great for if they're having difficulty breathing. It helps them sit up. It helps them to expand those lungs as well. So if your patient is doing any of those things, Fowler's is the position that you want to be, they'll want to be in. Fowler's is where you've got your bed raised to 30 degrees. Not quite all the way up there, but it's about halfway between flat and Fowler's. And this position is great because once again, it will still help with the lung expansion, so it'll help your patient breathe, but it's also used whenever your patient's getting tube feedings because it puts them in a position to where they're not lying flat. So if they vomit, they're not going to aspirate the contents back into their lungs, all right? So anytime you have a patient who is getting tube feeds, the expectation will be that they're at least at 30 degrees. Their head of bed is raised at least 30 degrees. So they would be in semi-Fowler's position, okay? Trendelenburg's, so this is when the entire bed tilted with the head of the bed down. So if I'm laying in the bed, Trendelenburg, my feet are a little bit more elevated than my head. Does that make sense? Almost like a seesaw, except my head is where the not heavy side is. And I'm not saying your feet are entirely up in the air here, but they're just elevated a little bit more than your head is, right? If you have a patient who has some problems with circulation, then putting them in Trendelenburg position will help with that. Also, once we get to mom baby, Trendelenburg is great because if the baby is coming or if the baby's head is on the cord, we can put the mom in Trendelenburg position and it will take pressure off of that cord and the baby will be okay until the delivery. Okay. That's something we'll learn when we get to mom baby though. There's also reverse Trendelenburg, which is where instead of having the head of the bed lowered, we're gonna have the feet lower, right? And we'll show you guys these when we come into the lab tomorrow. Sorry about that. There's a plate overhead. All right, so the entire bed frame is tilted down with the foot of the bed down, all right? If you have a patient who has a lot of GERD, any, gastric reflux disease, and they'll tell you this also, tilt your bed with the head of the bed up. You know, if you're at home, put your bed on cinder blocks so that you're tilted down so that it makes it harder for the gastric juices to flow back upwards. It keeps it down. Sometimes they'll tell you that. And then flat or supine, everything of course is horizontally parallel with the floor, right? Anybody who has any spinal injuries, cervical injuries, things like that, they're gonna stay flat or supine, okay? And if you're sleeping, right? That's the only thing I really wanted to talk to you guys about with as far as making the beds go. I just want to make sure that you guys are familiar with the what do you call it? The positions in the bed, right? So if I'm eating, which position should I be in?
Fowler.
Fowler's. Beautiful. Right? What if I have I'm having a baby and the cord is compressing?
Reverse Tengelberg. I
butchered
that word, but you know.
It's okay. The other one.
The Trendelenburg?
Yes, Trendelenburg. So remember, like gravity is going to pull that baby down. So if you put her in reverse Trendelenburg, it's going to make the baby sit more on the cord. But if you put her in Trendelenburg with the head coming up, then the baby's not going to be compressing the cord. That's the way I remember that one.
Oh, yeah, that's right.
All right. If I have a spinal injury.
Supine.
Supine. Beautiful. Beautiful. And if I have a spinal injury, how am I going to roll this patient?
To your side.
Using the draw sheet.
I feel like somebody said it, but I didn't hear it.
With the draw sheet.
You're gonna log roll them?
Yes, you're gonna log roll them. Okay. You're gonna try and keep that spine in the best alignment that you can if your patient has some sort of spinal or cervical problem. Cervical being cervical in the neck, not cervical like in the uterus. All right. All right. Any other questions on bed making that I can answer for you guys for the moment, or are we good with bed making? Perfect. Let's go on. I'm going to skip through several of these slides, so I'm going to stop sharing for just a second. Well, actually, no. Yeah, that'll make it easier. Hold on. Now we'll just scroll down to where I need to go. For this next section that we're going over, this is going to be in your Bible. So if you are following along, we're no longer in the skills book, although there is a chapter on oxygenation, I believe, in your skills book. But we skip to the Bible for this one. It's in chapter 14. We're not going to go through the whole thing of it right now. Have you guys covered respiratory in AMP?
That's what we're working on.
Doing it right now.
Very good. Very good. And this we're not going too much in detail right now, because once you get to next semester in med surg, you'll really go in depth in detail about more of these things. So I'm skimming the surface here. So if it doesn't make as much sense to you, it may not, just because we're not going to go in detail about it today. I just want you to know, like, you know, a little bit of the meat and potatoes. Really more of the side dishes, not the meat and potatoes. Right?
Okay. All right. Let me get my book real quick.
Very good.
So are we in the foundations in adult health nursing?
Yeah, the big Bible.
Okay. I was looking at the nursing care plan, but they're all big.
The encyclopedia.
Ugh. Oh, shoot.
While we're waiting, did anyone switch times for
me and the kids switched. So instead of me coming in at 11 tomorrow, I'll be coming in at 9.
Okay, perfect. Thank you. Thank you much. Thank you much. And Ralph, you come at what time? 11?
11 tomorrow.
Okay. Thank you so much. All right. I'm just giving everybody a couple seconds to grab their Bibles. Today we're going to be in the book of chapter 14. If you're following along. All right. So our objectives for this portion of the class today, we will talk about nursing interventions and related procedures for the patient receiving oxygen therapy. We'll talk about safety precautions that are necessary when your oxygen therapy is in use. We'll talk about the different types of oxygen therapy delivery devices. We'll touch on transtracheal oxygen delivery. I have not seen anybody with a transtracheal tube. Tracheostomy, yes. Transtracheal, no. So we're just going to briefly touch on that for just a little bit. Then we'll talk about what you're doing with your patient who is receiving oxygen therapy and your nursing care. We'll talk about suctioning a patient with a tracheostomy and providing trach care. And then we'll talk about oropharyngeal, nasopharyngeal, and nasotracheal suctioning. Has anyone ever had to suction a patient before?
I have.
Fun times, right? Did you did you suction orally or were you suctioning their tracheostomy?
Both.
Both? Very good. It's fun
Not
times.
the same patient, but I've done both.
Fun times. When I first became a nurse, it's probably in my first year of nursing, and I worked at a nursing home here when I first moved to Texas, and my patient had a trach. So I hadn't worked with a patient with a trach before. Well, he was a jokester. I didn't know it because I was new to the facility. I probably had only been there for a few days. And the lady that was precepting me, she was fantastic. And so she goes, have you done trach care before? And I said, no, I've not done anything with a trach before. And she goes, oh, it's fine. She goes, this patient is great. He's, 100% alert and awake, aware, everything. He'll teach you himself how to do his trach care. And I was like, okay, that's different, but that's fine. If he can teach me how to do it, that's fine. So I go in his room and, oh, before I start, does everybody know what the tracheostomy is? It's okay if you don't, we're all learning. So there is basically a surgical incision into the trachea and a tube is placed so that the air can go straight to the lungs. So you're bypassing the nose, right? You're going straight to the lungs. So it's there when people have emergencies sometimes, and we just need to be able to get more oxygen into their bodies. So they will give them a tracheostomy. So it's a tube that goes into basically right there at the little indenture between your clavicle, not your clavicle, yeah, your clavicles, right there. And so I go into my patient's room and he's super nice guy. And I'm like, okay, so the nurse told me that you were going to teach me how to do your trach care. And so he goes, yeah, I'm going to teach you how to do it. I said, okay. So, he walks me through all the supplies that I need. This is going great. He's so nice and informative and all the things. And then he goes, now you're going to take my trach out. I said, okay. He goes, you're going to take the old one out and then the new one is right here. You're just going to put it back in. I said, okay. Sounds easy, right? I took out the old trach. I took it out and he started acting like he was dying. Like he couldn't breathe at all. Like I'm about to freak out, guys, because he is literally putting on a show here, like grabbing his throat, like I can't breathe at all. And he didn't turn blue or anything, so I didn't worry that much yet, but I was kind of concerned because like he's having issues here. And then in a blink of an eye, he started laughing at me. He's like, your eyes got so big, you were so worried and concerned. And I'm like, dude, that's not even cool. That is not funny at all. But guess what? I learned how to change a trach and do all the trach care and all the things on that day. So I guess it's not as bad as it could have been, I suppose. Anyway.
I totally freaked out whenever I had to do my first one. Oh my gosh.
It's scary.
It is, because you think that you're not letting them breathe, and you think like, what if I go down too far, and then they kind of gag whenever you're like cleaning the trach itself. Whenever you stick the suction in to clean it, you have to like make sure you get all around the edges and everything. Gosh, it's heart wracking. Like I don't know.
It's very scary.
No way to describe it except just do it.
Just do it and be done, right?
Yeah.
I had my when I did my first trach change on a baby.
Oh, Lord.
Guys,
that's
like in the home setting, I was with the parents. The baby couldn't breathe that good, and the mom didn't want to participate. The dad was like, "You have to participate. You're gonna have to help us. We got to do this." And we got it done, but whew, Lord of mercy, y'all, it's nerve-wracking. Anyways, I digress. So let's go into talking about oxygenation. All right, coughing and deep breathing. Why do we need to cough and deep breathe as it pertains to our oxygenation, especially if we're not feeling well?
To loosen any mucus you may have in your lungs?
Absolutely. Loosen it up and get it out, right? We don't want that stuff sitting there.
Natural expectorant.
Yes, it is a natural expectorant. You got to get that stuff out. So especially when patients are having surgeries or if they're lying flat in the bed, we always tell them before surgery what we expect of them after surgery. So let's just say you had some sort of abdominal surgery. Let's say you had appendicitis. And, you know, nowadays it's not a cut you wide open and then, you know, it's laparoscopically done, but it's still a surgery. And so you're still going to have abdominal pain. So think about it. Whenever you have abdominal pain, do you tend to take a deep breath?
No.
You tend to breathe pretty shallow because it hurts too much to take a deep breath. Well, guess what happens if you breathe really shallow for a long period of time? It doesn't even have to be a long period of time, right?
You don't get enough oxygen.
You don't get enough oxygen. Things start to settle in your lungs, especially if you're lying down. You're not getting up, walking around, trying to get it out. You don't sit up. You're just lying flat in the bed. Then your lungs are going to get a little junky, and then you could end up with pneumonia. So there are several things that we can do to help prevent that from happening. And coughing and deep breathing is one of them. You may, if you had a surgery, an abdominal surgery, your nurse may have told you, or the RT may have told you, or the doctor may have told you, whenever you're lying here and you're awake, if you could put a pillow over your stomach and then take deep breaths and cough. That'll help keep your lungs expanded, all right? You're gonna control your coughing. Inhale and exhale with the mouth open will help you get the most amount of air into your lungs to help prevent any pneumonia. It'll help prevent any other complications that could come about with your lungs when you're having those procedures done, okay?
But really the thing that helps the most, I think, in that situation, I mean, for me, for one, because like the spirometer, because it forces you to
Yes.
like, take the deep breaths, because if it's just holding a pillow over your stomach, I mean, if you're in pain, you don't want to, you still don't want to cough. It's
This is true. We're going to talk about the incentive spirometer next, so I'm glad you brought that up. But on the surface, like, you know, sometimes you might need to clear your throat if you're post-surgery. You've had abdominal surgery, you need to clear your throat. And sometimes just won't do it. You need to do it. And if you have to cough, it'll hurt your stomach. So we tend not to cough. We'll go just to try to get it out, but that doesn't work. So we tell you to put that pillow over your stomach so that it will kind of split the area to help you feel like your stomach, everything on the inside is going to stay on the inside, right? Because we're all scared that once we have that abdominal surgery, if we cough the wrong way or something, everything's going to come spilling out of our stomach. Maybe that's just me. So those are some of the things that they're going to tell you when you're in surgery. All right, Ms. Castillo, since you brought up the incentive spirometer, what is it?
The spirometer, it's when you take a deep breath and like you blow into it with all your force to show, well, we just talked about this yesterday, to show like is it the title? I don't remember the name of it now. I have to look at it again, but it's like to show how much air your lungs can hold, how much you're able to breathe in and out. So it basically decides how much oxygen your body's receiving.
Yeah, it's helping to, it's going to measure how deeply you can inhale. Right? So when you're laying flat for a while or after surgery, sometimes you just lay there and you can't take a deep breath in. You can't really expand your lungs like they need to be. And this is where people get the collapsed lungs, and this is where they get pneumonias and things like that. So if you guys are ever working in a facility like a hospital, a surgery center, anything like that, most of the time, you can tell your doctor, hey, this patient just had surgery, I need an incentive spirometer, okay? You can tell them. And most of them will prefer it. Kids will use them, adults use them. It's very easy to use them, but it's very important. This isn't something that you just want your patient to ignore doing. This is something that you want to follow through and make sure that they're actually doing, right? So how this works is, did she show you, if you guys were talking about this yesterday, did she show you how it actually works?
No.
Take that as a no. Okay, so what you'll do, here's the mouthpiece, and they come right out of the package just like this, right? So you're gonna close your lips around the mouthpiece, and then you'll inhale. I'm sorry, do what?
She did tell us how to operate this machine yesterday, the spirometer.
Oh, it's okay. I'll go over it again. That's not a problem.
No, I'm not saying that so you can't go over it, but I was just putting it out there that she did.
Oh, very good. Very good. All right, so you put your mouth around the mouthpiece, then you're going to inhale slowly and deeply, and it's going to raise your little indicator over here. And what we want to do, whoever is in charge, the respiratory therapist, the doctor, whoever, will set this little yellow tab right here to where they want you to raise this too, right? So sometimes right after surgery, it might not go up very far. But as long as you keep practicing, you should be able to get to your goal wherever they have marked it, okay?
You said 10 times
10
in
times.
an hour?
10 times an hour, absolutely. And so what we usually tell patients, because guess what, what are your patients usually doing when they're in the hospital?
Watching TV.
Watching TV. So you know what? They're laying there, playing on their phone, watching TV. So we usually say whenever a commercial break comes on, just do it, right? And they only need to do this while they're awake. You don't need to wake them up every hour while they're sleeping at night. But during the day while they're awake, they should be doing this 10 times an hour, okay? And this is going to help keep their lungs expanding as they should be, right? So like I said, if you work in an area where you're going to see surgeries and things like that, go ahead and get familiar with this piece of equipment, because you can tell your doctor, hey, we need an incentive spirometer for this patient, okay? Sometimes they already have them sitting out for the patient, when they return from surgery, because you're not just going to sit here and lie here. We got work for you to do, sir or ma'am, okay? Get your respiratory therapist involved as well. They need to know who's on the floor that's got these, because in the event that the patient doesn't do this, or they're not able to get this device floating up to where it needs to go, RT needs to be aware in the event that the patient starts to decline, if their status starts to decline. RT should be aware so that they're already on their radar, and they say, oh, I know why I'm being called to this room, because they had surgery, they're not using their incentive spirometer, or whatever the case may be. Okay? So befriend your respiratory therapist. The incentive spirometer isn't the only thing that we can use. I don't know that I've seen the acapella used in adult settings, but we do use it in the children's settings. So this is great for people who have COPD, asthma, cystic fibrosis, things like that. They're gonna blow into it. It makes it a little easier for them, right? For kiddos, we use bubbles. If you don't blow hard enough, you don't get bubbles. So kiddos like bubbles. We give them bubbles and we tell them to blow the bubbles after they've had the surgery. Because sometimes if they're too young, they may not understand how to use the incentive spirometer. Right? And then you've got this friend right here, your peak flow meter. Has anybody ever had to use one of these, or have you seen them used? I don't know if this is more old school. I haven't seen it in several years.
Years ago.
Years ago, yes. When my daughter first got diagnosed with asthma, we used a peak flow meter. And all this does is tell you your lung capacity on any given day. You blow into this thing, and it tells you if your lungs are, you see this little red, green, and yellow button on this side right here? So your doctor will give you a, let's see, if we're doing this for asthma, it's an asthma action plan. And it'll tell you your green number might be at 300. I'm just making up numbers here. Or no, your green number would be up here at the top. So let's just say this top number is 800. Your yellow number would be maybe 400, and then the red number would be like 200. That means if you blow into this little thing and you're in the red, that means you need to use whatever emergency treatment you have. So if you're taking albuterol, then you need to use it, right? If you're in the green, that means keep doing whatever you're doing. So if you're taking your Singulair, you're using your Flovent or Advair, whatever your preventative treatment is, that means it's working, you're good to go. If you get into the yellow, you might need to use your albuterol every now and again, because there may be some allergens or something out there in the air, and it's affecting how your lungs are working. And then if it's in the red, that means your lungs aren't working that great right now. You need to use your emergency inhaler and probably go in to see your doctor. Okay, so this just measures the flow of the air through your airways. So it just kind of checks to see how your lungs are doing. And you guys will go into this later. Like I said, I'm skimming the surface here for some of these things, right? What is hypoxia?
When you don't have enough oxygen?
Absolutely. You don't have enough oxygen. You're not oxygenating well, right? So what do we say your normal O2 sat is?
95 to 100.
95 to 100, absolutely. So here our slide says normal O2 sat 90% or higher. So depending on what the patient's problem is, we might not fuss if we see a 92 or a 91%, okay? Or 90%. But typically the general population is going to be 95 to 100. But we are going to fuss regardless if you're below 90, for sure, okay? Normal respirations are what?
12 to 20.
12 to 20. Oh.
12 to 20. And since we're on a roll, what's your normal blood, not blood pressure, what's your normal pulse?
95 to 100.
Say it again?
60 to 100.
Beautiful, 60 to 100. All right. And then what's our normal blood pressure?
120 over 80.
20 over 80.
And below. Beautiful, beautiful, beautiful. If you're doing arterial blood gases, which you guys shouldn't have to do, but if you like to read lab reports and things like that, especially if you have a critical patient, normal PaO2 is the arterial blood is 80 to 100. Okay, and that's something only if your patient has labs drawn, you'll find that out. You're not going to see that from just the pulse oximeter or anything like that. That's something that you must draw blood to see, right? Right, so when your patient has hypoxia, there is reduced oxygen content in the tissue and the cells, and those cells will start to slow down, they'll start to die, okay? If your patient becomes hypoxic, some early signs would be that your patient gets anxious, right? They might get pretty agitated. They may be restless. Those are early signs, and sometimes those signs may be so subtle that you don't realize that's what's going on, especially if they're not hooked up to pulse oximetry for monitoring. You may not realize that. You might just be like, oh, you know, let's just give her a Snickers bar so that she can calm down and be fine, right? When in reality, it's hypoxia that's the problem, okay? So those are early signs. If your patient starts to exhibit cyanosis, which means they start to turn blue, especially blue around the lips, if they start to retract, you start seeing them work really hard to breathe, or if they start to sweat, then that could be signs of hypoxia, late signs, of course. Okay. If you notice your patient has hypoxia, especially if you notice they've got some junky lungs, there's a lot of crud in their lungs and they're having to cough up a lot of things, please offer them lots of water. Because when you're drinking a lot of water, that helps to liquefy those secretions and helps to get them out, all right? So if your patient starts to get hypoxic, or if they have, you know, a nice junky cough, or they're not coughing up what they need to, give them more water. So you'll notice if you're in a hospital setting, your provider may order some IV fluids to help with that as well. But you need to offer your patient fluids to drink as long as it's okay for them to drink anything, right? Water, not milk. What happens if you give your patient milk? I know.
It increases the thickness of the
mucus.
Yes, it does. So remember that, guys. Even for us, if we're sick on a normal day, the day to have your extra milk and, you know, what do people order from Starbucks? With the frappuccinos and the whip and all the things. Not a good idea to have all that extra stuff, all the milk product whenever you are needing to cough stuff up. You need water. You'll notice on your, if you take Mucinex, you have to drink a bunch of water when you're taking it, okay? So sometimes when you're looking at what is that thing called? Directions. We all overlook it. You know, I'll take a Mucinex if I start to get that cruddy feeling and I need to cough some stuff up, but then I forget to drink a bunch of water. So then I just have this stuff just sitting here because I can't get it to come out because I'm not drinking enough water to help it liquefy. So make sure that you're telling your patients, let's not drink so much milk right now. Caffeine either, no caffeine or low caffeine. Other dairy products like a bunch of cheese, ice cream, things like that, and sugar. Those do not help to liquefy the secretions if your patient needs to help get them out. You need to increase their water intake. Okay. Right. Standard steps. You guys, you have pages and pages of this in your book, so I'm just going to kind of briefly touch on the steps that you would take for oxygen therapy. Okay. You must do this with every patient. And guys, what steps do you take before anything you do to your patients?
Wash your hands.
Wash your hands.
Identify the patient.
Identify your patient.
Gather your supplies.
Gather your supplies.
Tell them what you're about to do.
Tell them what you're doing. And there's one more really important one.
Put on gloves.
One more. Put on gloves, yes. We identified our patient.
Check the medication.
Yes, check your orders. Okay. So we don't just run out here slapping oxygen on all of our patients, okay? You must have an order. You should have an order. Now, obviously, if there's an emergent situation and your patient's O2 sats are 85 all of a sudden, obviously help your patient, but you need to get an order for it as soon as you're done. Call the doctor while you're putting the oxygen on. Hey, our sats are 85%. We need oxygen. I'm putting it on the patient right now. I just need an order. Okay.
Is that even with the nasal cannula?
Yes. Oxygen is a medication, so you need an order. All right. Some places will have standing orders. Some, not all, but some, especially for the patient who doesn't need oxygen all the time. They may say, please put oxygen on patient to keep O2 sats above 92%. You may see orders like that sometimes where you're working. So just be on the lookout for those. But it is a drug, and you must follow those 6 rights of drug administration when you are giving it, right? So if our patient, let's just say you walk into your patient's room and her O2 sats are 88%. What is the first thing that you're going to do?
Ask them to cough.
Okay, we can ask them to cough, but before we even do that, what do you think we can do? Let's just say she's lying flat in her bed.
Oh, raise her head.
Raise her head.
Raise the head of her bed. What position should we put her in?
Fowlers.
Fowlers.
Absolutely. Fowlers or semi-fowlers, we'll put her in that position because that will help with maximum lung expansion, right? If Miss Johnson her O2 sats have been 95% this whole time she's been in the facility, and all of a sudden she's 88%, what's something else that we can do to assess her? Maybe she's got some junky lungs, right? So we can also take her lungs. Let's see what it sounds like in there. Because remember we said if we hear rhonchi, we can get her to cough. She can clear those secretions. Her O2 sats may go up before we even try to do. I think I'm echoing somewhere. Right? So we can also take her lungs because if she has rhonchi there, we can get her to cough and expectorate what's in there. And then we may not even need to do anything else. Right? Her 88% may go right up to 94%. Maybe that's all she needed was to elevate her head of her bed, get her to cough that up, and then she's good to go, right? In the event that she does not respond, or it's not rhonchi that you hear, maybe it's crackles that you hear. She's been laying in the bed for the last 12 hours because she felt like it. Nobody made her get up, nobody made her turn over or anything like that. So she's been laying in the bed. She didn't want to be bothered. And now her sats are dropping, right? So how about we take a break right here and we'll come back and talk about whatever I just named this lady that we're talking about and her oxygen, okay? Let's take a break until 11:10. All right, everybody coming back and sign into the chat for me. Love on camera, please, and thank you. Just a little bit more to go, and then I can let you guys go for the day. Everybody's back and signed in. All right, go back to our friend here. We were talking about, I can't remember what I named my patient, but I'm going to call her Martha now. We're on a first name basis at this point. So let's just say that Martha, we know we went in her room, her O2 sats were 88%, and we listened to her lungs, noticed they were a little junky, so we had her, well, the first thing we did when we went in her room was we raised her bed to see if that would help bring her sats up. And she stayed at 88, maybe went to 89, but she kind of hung out around there. So then we listened to her lungs to see, you know, what's going on in there. They sound a little junky, so we had her cough and breathe for us. And then her stats still stayed the same. So now we may need to give her some oxygen, okay? Also, whenever you have a patient and you're looking at her pulse oximetry, make sure it's reading correctly. You may need to take it off. Let's just say it's on her right index finger. Let's put it on her left index finger and see if we get the same thing. You know, maybe she was trying to comb her hair or something and the machine wasn't reading correctly. So we move it to the left hand. She's 95% now. Good deal. We have nothing else to do. But let's just say we move it to the left hand and now she's still 88%. Now we need to give her some oxygen because at this point we see maybe she's nasal flaring. Maybe she may not be turning blue yet. Maybe she's getting a little anxious, a little restless. Maybe she's having difficulty breathing. She might be retracting, using those intercostal muscles to breathe that we normally don't see when they're breathing, right? So maybe she's exhibiting all these signs that she's having some pretty hard difficulties here. So we need to give her some oxygen, right? So the first thing we want to do for oxygen, we want to make sure that you have some sort of humidification. So when you're dealing with O2, so if it's you and I and it's on a normal day, what part of our body provides humidification for the air that we're breathing?
I understand the question.
So when you're breathing, there's a part of your body that kind of helps to warm the air when you're breathing. Your
Nasal
nose.
passages.
Absolutely. Your nose. So if I put oxygen via a nasal cannula to your nose, that air blowing straight into your nose could dry it out, right? It's very uncomfortable. Have you guys ever had dry nasal passages before? It's terrible. It's very painful. It makes you just not want to breathe. And I deal with that a lot sometimes, especially whenever the seasons change and things. And then my husband's like, why don't you just breathe through your mouth? Because, you know, that would eliminate the problem of my nose hurting because I breathe through my nose. But I'm such a nose breather that that's not even comfortable to me either. So I've been trying to say people need to make nose warmers throughout my life, but nobody's really taken that and ran with it yet. So there you guys go. If you guys are creative, please.
Why don't you make it?
I don't have time to make a nose warmer. I'm not a knitter. I don't do those things. But the best thing for me right now is wearing a mask. Y'all, I'm like so excited that I can wear a mask wherever now because it keeps my nose warm and it keeps the air warm so that in the event that my passages do start to get dry, I'm not continuously breathing in like when you're in an air conditioning room and things. Anyways, now that you know my life, we're best friends now. Nice to meet you. Anyways, so since we're going to put this oxygen to this patient's nose by using a nasal cannula, we want to make sure that we're not drying out their nasal passages while we're doing it. So we're going to use some humidification. So there is typically a bottle of sterile water sterile saline. I don't know which one it is. It's one of the two, but it's sterile and it's used for humidification for the purpose of giving oxygen. So you would hook this up, and this will probably make more sense when we're in the lab tomorrow, as opposed to me talking about it right now. But you would hook it up to the flow meter on the wall. Let me see if I can find a picture of this. It might make it a little easier. Has anyone ever had a patient that's been on oxygen?
Yes.
Yes.
Do you trace where the oxygen's coming from? Like, do you look at, the flow meter on the wall or anything like that, or do you just make sure it's
Our flow meter isn't on the wall. We have either the portable tanks or the ones that stay in their rooms, the big gray box looking thing.
the concentrator?
That.
Very good. Let me see if I can find you a picture here. What am I looking for? Oxygen flow meter. All right, so these things right here, you're gonna see them attached to the wall. They'll be attached to the wall in any facility that you work in, unless you're using the big concentrator or the oxygen tank, okay? So it looks like this, and you'll see a knob. You'll see numbers, calibrated numbers, and there's this little itty bitty silver ball in the inside. When it's off, it's resting at the bottom. Once you turn the knob, it goes up to however many liters you need. So if you need 2 liters of oxygen, then you're gonna move that little ball until it sits at the 2.
Usually all my residents are either on like 2.5 or 2.
Yes, and there is a reason for that, most likely. So if you have a patient who has COPD, they cannot have more than 2 liters of oxygen. And that is because when you give them more than 2 liters of oxygen, it will take away their natural drive to breathe. Normally, they thrive on having more CO2 in their bodies. And so when you put more of the oxygen in, they can't breathe because you're taking out that CO2 that they've been depending on to breathe. Once they get, the way your body works is you get a certain level of carbon dioxide in your body, and it's like, oh, it's time to breathe. Let me get that out of there, okay? So that's basically what happens. But for people with COPD, their lungs don't function as yours and I's do, as mine and yours. They don't function properly. And so their drive to breathe comes from having that extra CO2 in their bodies. So when you put the O2 in, the CO2 comes out. So if you put too much O2 in, too much CO2 will come out, and that means you're taking away their drive to breathe. They may feel worse. It's going to make them worse than better. So for COPD patients, 2 liters of oxygen is the maximum amount you can give them. Okay. That's just food for thought. You'll learn that more when you're talking about respiratory, probably in A&P, but most likely you'll hear the most of it when you get to med surg. Right? That is always 2 liters and no more. Okay. They may be teeter-tottering with your other patients that may be at 2.5 liters, but 2, no more than that is usually what they take. So when you have your flow meter, your humidification, do you see this little, I don't know what this thing is called, at the bottom here? Your humidification, whatever you're using for humidification, screws onto the bottom here. And once you turn your oxygen on, you'll see bubbles in the humidification chamber. So whatever liquid is humidified is causing your humidifying water. It's going to have bubbles in that chamber, right? When you turn the oxygen off, the bubbles go away.
Like
So,
condensation?
For what now?
Bubbles like in condensation, or there's actual liquid?
So there's actual liquid in there. So you're using your sterile water, and it's got, it's water. It's like a container full of water. Let me see. Hold on. Let me see if I can find a picture of it so that you can, hold on.
Okay. Thank you.
Thing at you. Welcome. I'm messing up all the buttons here. Hold on. If I touch them all, something will happen. Humidification or flow. me see what you guys will typically see. These are all old. They don't look like this anymore. I don't know. Maybe they look like this in a home setting. Hold on. Let's see. Sterile water for humidification. Here we go. All right, so sharing my screen once again. Now remember how that flow meter looked. I don't know if you can see this. This is what the top of the humidification bottle will look like. It's got this little screw cap on it. It screws right to the bottom where I told you it would. And then this bottle is full of water. So once you turn the oxygen on, you'll see bubbles in this water.
Oh, I gotcha. Yes.
And so it's providing humidification so that your nasal passages don't get dried out from the oxygen that we're putting through your nose. And so when you put the humidification up, your patient has the O2 tubing on, they're in a nasal cannula, it will hook up to this. Okay. And we'll show you guys. I think we have these in the lab. If we don't, then I'll pretend. I'll make a pretend. Okay.
Okay.
Very good. All right, I'm gonna stop sharing real quick so I can get back to where I was. All right, so we said when you've got your patient and they're on oxygen, you want to make sure that they are that you're providing that humidification as well, because it's very uncomfortable to have that air, that oxygen blowing into your nose, especially if you're going at 4 or 5 liters, right? It's blowing in there, drying everything out, and it's very uncomfortable. So you want to make sure you're giving them that humidification. Okay. Right. So like I said, you'll want to make sure it's attached, make sure it's bubbling once you turn it on, and then you're going to put your O2 onto your patient. So we'll talk about this in a second, but there are several different ways that you can give your patient O2, but right now I'm just referring to if you're using a nasal cannula, and that's where it's a little plastic tubing. It's got 2 prongs that fit inside of each nair, and then you will bring the tubing around the patient's ears and secure it by it's this little pull, what is it called? A little attachment that helps to tighten it so that it doesn't come off, right? So if this tubing, it's not heavy, but it's resting behind your ear, which is it could be kind of a delicate position, a delicate area. Make sure that when you have a patient that's on oxygen, that you're monitoring behind their ears, okay? Because you can have skin breakdown behind the ears from that. All right, so we've got our patient's oxygen on, and now we just want to make sure it's working, right? So I'm gonna start her at 1 liter and see what that does. And don't expect for her pulse oximetry to reflect oxygen as soon as you turn it on, all right? It might take a couple seconds, a few breaths for her to get it in her body. So if she's at 88%, I'll put it on 1 liter, all right? She goes up to 89%. She's staying there for a while, so I'm gonna turn it up to 2 liters. She goes up to 92%. I'm gonna leave it there for now because typically whatever your order says is where you wanna stay. So if the order is O2 for less than 92%, then I'm good leaving her at 92%. Now if she drops to 91%, then I want to revisit that at that time, okay? I've also noticed, I'm gonna reassess my patient at this time. I put the oxygen on her. She's breathing a little bit easier now. I don't see her nasal flaring anymore. She no longer is using her accessory muscles to breathe. I don't notice any cyanosis around her mouth, and she's not agitated, no more anxiety. O2 sats have gone up to 92%. Skin is pink. She's not complaining of anything right now. Okay? Make sense? It's a process. But once again, make sure with oxygen, it is a drug, so you want to make sure that you are using your 6 rights, following when you're going to give that, okay? Be safe, guys. If you have a patient who's on oxygen, especially if you're in the home care setting, if you're doing home health, make sure that your patient and their families know, right? It is combustible, All right. So if you have oxygen there, we don't want to put you in the kitchen. Make sure your patient outside their home has a sign that says no smoking. Also, make sure your patient doesn't smoke because they will try it. Okay. They will try it. Trust me. I've seen patients that have had the burn marks on their face because they just had to have a cigarette and they didn't care that they were on oxygen. It's oxygen, combustible. So I don't know how you want to tell your patient, try not to, scare the life out of them unless you have to, right? But make sure that they know, don't smoke. Oxygen is colorless, odorless, tasteless. So if you've got your oxygen tank beside you and it's on and open, you're not going to see the oxygen, okay? You're not going to taste it. You're not going to know it's there. So if your tank is open and then you go to light a match, then you have just blown yourself up, essentially, okay? So it will not burn up or explode, but when you relight that match in front of it, it will support the combustion of it, okay? So you want to make sure that your patient does not light up anything next to it. Make sure they're not close to any electrical appliances and things like that. If they're using, cords, electrical cords and things, everybody's got their phones plugged in and this, that, and the other, make sure the cords aren't frayed. And I know I have pets, so I have to go through and check all the time because these critters don't care. They just chew your stuff up anyways. They'll get a mild shock and they'll keep going like it's not a problem. So make sure that everything that they're using is intact. No flammable clothing like wool. Tell grandmama to put that polyester suit away. She can't be wearing it while she's got her oxygen on. I apologize. We're just gonna have to wear cotton. All right, no wool blankets, nothing like that, okay? No petroleum products. I told you guys this yesterday. So if you have a patient who's on oxygen and they need something to moisturize their lips, nothing containing petroleum because it will support combustion with oxygen, right? We don't want to blow up their face.
I got a question.
Uh-huh.
When somebody has a cannula in their nose, how do they get water in the tube?
So because of the humidification, right? Do you guys have humidification at your facility when they're using oxygen?
I don't understand what you mean.
So like the little tube or something full of water that's attached to the oxygen chamber. I know the concentrators have a place for them, but I don't think I've seen a lot of people with tanks with it.
We have the it's on the whatever you said the thing was called.
The big thing that sits on the floor?
That.
Uh-huh. So sometimes water will kind of go up in there and you just have to tap to get it out or replace the cannula itself. Okay. And sometimes, if you have a nose breather, when you put your mask on, sometimes, well, I know for me, I wear glasses. So we kind of it fogs up a little bit. And over time, that'll kind of make some moisture. So that'll get stuck in that tubing as well.
Gotcha.
So yeah, if that happens, sometimes it gets stuck in there. You just have to change the whole cannula out. All right. Make sure that you're not giving the patient too much oxygen because too much, if they become toxic, can cause scarring of the respiratory tract and it can give them difficulty breathing. For babies, we have to be very careful because it will cause those problems as well. And those problems will last their entire life. So we have parameters that we stick to when it comes to babies and administering them oxygen because we don't want to do that. Make sure you're telling your patients and make sure you know in the facility that you work in, if you have patients on oxygen or if you have oxygen in the building, know where your fire extinguishers are located. All right, safety first. All right, let's talk about atelectasis. Anybody know what this is? Anybody ever had it? Nope. It's not fun. All right, this is a partial or a complete collapse of the entire lung or an area of the lung, right? This happens when those alveoli become deflated or they're filled with some sort of fluid, right? And we know, you guys, you said you're on the respiratory right now in A&P. So we know the alveoli, they are where the gas is being exchanged, right? If that's filled up with fluid or completely deflated, you can't exchange gases, all right? So you're gonna have difficulty breathing, right? Your symptoms might be dyspnea, rapid shallow breathing. Your patient might be wheezing or coughing a lot. It's not comfortable. I haven't had it before, but this is what they say. It's not comfortable. It's painful, all right? All these things that I've showed you, like the incentive spirometer, the acapella, blowing bubbles for little kids, those things are what we're doing to help keep those alveolar sacs open to prevent atelectasis from occurring, okay? We don't want that to happen. So let's just say your patient, typically after surgeries, we want your patient, you want our patients to get up and move around to help them expand their lungs. But let's just say your patient is just in so much pain, or they had surgery on both their feet. They can't get up and walk, right? So one of the things we can do as nurses is to have them sit up at the side of their bed with their feet dangling to help promote drainage and help keep those lung bases open. Help them breathe a little bit better, not just sitting them up in a Fowler or a semi-Fowler's position, but actually having them sit up on the side of the bed, okay? Help them breathe, take deep breaths in, deep breath out. And this way they're not just laying flat, they're not just laying, semi-flat, or, even in semi-Fowlers or Fowlers, they're actually sitting up, and we're able to get some of those lung juices flowing so they don't sit in one area and cause a collapse of their lung, okay? This is very common after surgery, so that's why we try to prevent it by using the incentive spirometer, right? All right, so now let's talk about all of these different oxygen delivery devices that we have. Most of us know about the nasal cannula, where I said, it's the tubing, plastic-like tubing, and it's pretty pliable. You have one prong per nose. You have one nose per nair, one prong per nair, and then the oxygen flows through the little prongs, okay? We use nasal cannula if our patient needs to get between 1 and 6 liters of oxygen, okay, per minute. Like we said earlier, this is ideal for your patients that have COPD or emphysema, all right? We're gonna go at 2 liters per minute. If you have a patient with a nasal cannula, make sure that they have a cord long enough to go to where they need to get to. So let's just say they're laying in the bed. Make sure that their cannula is long enough for them to be able to get to the restroom. All right. Also, make sure that it's safely positioned so that they don't trip over it. Okay. So that's a nasal cannula. You can have 1 to 6 liters per minute of oxygen with a nasal cannula. All right. If we're using a simple face mask, right? When you need a little bit more oxygen, just to say your patient needs 7 liters, right? You can put a simple face mask on them, right? That's going to give you 5 to 8 liters of oxygen per minute, okay? 5 to 8 liters. And then if you need a little more oxygen, we can use a Venturi mask. This mask will allow for a precise amount of oxygen to be delivered, right? So while we're looking at the flow meter, it's calibrated and you can kind of sort of see where your numbers are located. With a Venturi mask, you can actually calibrate your O2 to exactly what you need. If you need exactly 5 liters of O2, you can calibrate it to that. Venturi mask is good for 4 to 10 liters per minute of O2. Right. Then you have a partial rebreather mask, right? This has one-way valve that will prevent the patient from inhaling any expired air. Anything that they've exhaled, they won't breathe it back in. There's only one valve there, okay? This is used in severely hypoxic patients, right? You can go from 6 to 12 liters of oxygen with this one. 6 to 12 liters per minute of oxygen. Your non-rebreather mask, this is when your patient, sometimes your patient's hyperventilator, things like that, or you need to make sure that they're getting every single piece of oxygen you're giving them. You're going to use a non-rebreather, and this goes from 6 to 15 liters per minute. Okay. So nasal cannula, you've got 1 to 6 liters per minute. Simple face mask is 5 to 8 liters per minute. Venturi mask is 4 to 10 liters per minute. And guys, this may not make any sense to you guys yet. When we go to the lab tomorrow, we'll show you guys, okay? And that way you can touch and feel and see and all the things, right? Right, partial rebreather is 6 to 12 liters. The non-rebreather is 6 to 15 liters of O2 per minute. I didn't spend a whole lot of time on the oxygen hood, the halo, or the tent because I have not seen them used as often, if at all, in recent years. These we use more in pediatric patients. Does anybody know what croup is? Has anybody's kid had a croup before?
Group is like the RSV kind of?
No, I mean, you can have RSV and croup at the same time. It's not good. But croup is where if your kid, sometimes it's caused by a virus, well, it is caused by a virus, and it's where there's a barking cough. It sounds terrible, like terrible. It's very scary for a parent to hear. And the only thing that we can do to help calm down that cough and to relax those, relax your, oh geez, where's my word? Oh geez. Guys, I'm having a brain fart right now. Relax those, your lungs, I guess, is what I'm looking for here. That's not the word I'm looking for, but it'll come to me. It helps relax and helps you breathe better. Used to be we would take the child and put them in this tent that's misting and blowing oxygen around, right? We don't do that anymore. I haven't seen it. Now we give them steroids. We give them albuterol. We give them racemic epi, which is another form of albuterol, and then usually they do better that way. But used to be once upon a time we'd put them in this little tent, and it would just blow oxygen at them, and it would calm them down. It would relax those muscles to help them breathe a little bit better. But we don't see that as much anymore. But it's here just so that you know it's there. It's a thing. It could still be a thing in some other places.
What was the numbers again for the non-breather mask?
Non-rebreather is 6 to 15 liters per minute.
That in our book so we can like make sure that we have it.
It is in
I
your
was
book.
looking for it in the book.
It is in your book.
But
Are you in the Bible?
I only see the cannula
Yes.
one that says 6 to 10 liters. Maybe somewhere else. Anybody have a page number?
Hold on. It is on page 340 at the top.
Oh, okay. I was on 342. Okay.
Okie dokie. Moving on. All right, home oxygen delivery. Ms. Johnson, is this what you're talking about that you see? This big thing that sits on the floor?
Yes.
Yes. This is called an O2 concentrator, right? You'll see these a lot in the long-term care facilities. They're just easier to tote around than having to get these big old tanks. All right. Well, this tank isn't big, but I've had remember I told you about my patient that I had to help bathe yesterday that was almost 700 pounds? She had to have one of these concentrators and 2 of the, I don't know how many liters of O2 they held. They were huge. The tanks were almost as big as I am. They were huge. And we'd have to keep 2 of those in the concentrator on hand for her at all times. Make sure, for if you have a patient at home that's on oxygen, make sure they know to get their tanks refilled or replaced before they get empty. All right, especially your patients who need oxygen, because, I mean, if you need oxygen and then you run out of oxygen, it's not a good thing. All right? It's a good idea to alert.
Have no oxygen.
Exactly, they will have no oxygen. So we want to make sure that we're telling them, keep an eye on your oxygen levels. If there's oxygen, if it's an oxygen tank, the little meter that's attached to the oxygen tank will actually tell you how much is left there. I don't think we have any O2 tanks in the building. Otherwise, I'd show you guys how it works. But whenever we go to a facility, at whatever point we do that, then we'll show you then. Okay. Remember, no smoking. So make sure there's no smoking signs up in the home, outside the home, right? No flammable clothing. Grandma can't wear her go-go clothes anymore, no polyester, nothing like that. Make sure they refill it before it's getting empty or when it gets close to getting empty. And they'll let you know if they're using a service to help them with their oxygen, they will say, this is the level that you need to call us and come and replace, okay? Like I said earlier, make sure that the tops of the ears, that you're checking them to make sure that it's not breaking down, because if you have a nasal cannula on, it might get a little heavy on the ears, and so you want to make sure you're checking that. A brief moment on transtracheal oxygen, right? Your patient with a tracheostomy may have this, right? So if your patient has a tracheostomy, they're not going to be breathing through their nose. Remember that. So if emergency comes up, it's not a good idea to put a nasal cannula on them, okay? I tell you this because I've seen it before, all right? It doesn't make sense. They have a tracheostomy, they're breathing through the hole that's in their trachea, not through their nose. So if you have an emergency, putting the nasal cannula there is not going to do anything, right? So can a person with a tracheostomy, can they still eat or drink?
Yes.
Yes, absolutely. Right? They have a cap that they can put on it. They can still talk when they put the cap on. My friend that was tricking me, telling me that he was, choking and couldn't breathe when I took his trach out, he just put his hand over the stoma so that he could talk to me before I put the new trach in. So some people aren't going to do that, but, there's a cap that you can put on the end of a tracheostomy. Has everybody seen a tracheostomy before? Please hold.
Yeah, in a picture. I don't think I've met anyone who has.
Right, so this is what happens. They make a surgical incision in the trachea, into the skin, into the trachea, and they will put this little tracheostomy tube in place to hold it open, right? So it looks like this. Typically, before it's put in, the balloon is not inflated. This is what's going to keep it in place. Some are cuffed, some are not cuffed. This is in your book, guys. This is in the Bible, in the same book that we're using for today. So it's there if you need to refer to this picture just to see what it looks like. But this is there. Once a person has a tracheostomy, they're going to have this trach collar that's going to give the oxygen, deliver oxygen to them. Okay. Right. It's typically secure.
Page 348.
Thank you, ma'am.
352.
Well, it's 352 on my computer, but I don't know if the page is lined up exactly with what's in the hard copy of the book.
Oh, okay. This one shows a picture of a patient it's on the outside. It's not like a sagittal cut like that.
Yeah. So when you have a patient with a trach, this is what it's going to look like. You're going to see they're going to have on a collar. If they're receiving oxygen, they're going to have their little hose, and all the things are going to be hooked up to go straight there. You see there's a little vent here to let some of that moisture escape as well. And then they have trach ties that go around the back of the neck. You as nurse, you need to make sure that those trach ties aren't too tight, because that can impair the skin integrity. So you should be able to fit at least 2 fingers or a finger, at least 1 finger underneath. You don't want it too loose because you don't want the trach to become dislodged. And basically, if you see right here on this outside of the body, you see 2 little slits right here? That's what attaches that trach collar to it. Okay? So you want to make sure that your patient's tracheostomy tube is secure and intact with your patient. And our goal is to make sure that stoma site remains clear, clean, dry, intact. Typically, right in between the skin and the trach, there's going to be gauze there. It's usually a split gauze. Oh, we have a patient. One of our patients in our in the lab has a trach. So we can show you tomorrow. It's not one of your skills that you get checked off on, but I can at least show it to you so that you know what you're looking at when you see it, right? But you'll typically have gauze here, and you want to make sure that you're keeping that clean. It needs to be, trach care should be provided as ordered. So whenever the doctor orders you or whenever it is soiled. You don't want to leave something wet with secretions sitting on the skin, okay? Because then you'll,
I apologize. I don't mean to interrupt, but did you say we're not going to be checked off on that?
At least not right now.
Sometime during the course, or you don't think so?
I cannot remember because I didn't teach skills last semester or last cohort, so I'm not sure if it's part of your advanced skills. But I don't remember being taught trach care and all the things trach related when I was in VN school as well. But for right now, say what?
I was about to say that we learned that over there at the other school. I mean, there's just a lot of different things that you guys don't seem to be teaching at this school that at the other school they had offered and certified for. So
also a VM program?
Yeah, at the other LVM program I used to go to, they taught us to do trach care. And we had to do trach care when we actually got out to the assisted living on our clinicals.
Well, and so typically now, the places that we've gone, we didn't have any patients that had trachs. So I know that one of the facilities that we went to had a section of their facility where they had ventilated patients. So obviously there were trach patients there, but they wouldn't let the nurses do anything, our students do anything.
Oh, okay.
It was just for observation.
Okay.
So yeah, it's really, I guess it's because of where we're at. I don't know. So if we end up having patients whenever we go back to clinicals and there is a tracheostomy patient there, then absolutely go with that nurse and you know, learn all the things. Okay.
Right.
Going back, hold up, let me stop my share again. Go back to where I was. Slide, what time is it? Ooh, I got a few minutes. It's a good thing we only have a few slides to go. Oops, I'm messing up over here. Share my slide. Yeah, I mean, you'd be surprised. Some of the things that we cover in class, I didn't even see until I became an RN. Some of the things, not all of them, but my trach care stuff, I was almost a year into nursing before I had my first trach patient.
Wow.
So, you know, you'd be surprised. All right, let's talk about suctioning. Anybody know what this thing is called?
A suction
suctioning tube?
Cannula? Is it called a cannula?
It is a suction tube. The proper name for it, if you yes, who said that?
Haley.
Beautiful. Thank you, ma'am. It is called, well, some people call it a yanker. I call it, because there's a U in the title or the name of it, I call it a yank hour. So it depends on who you're dealing with as to what they're calling it, but most people are going to call it a yanker. Yank hour is what I call it. This is for oral suctioning, oral pharyngeal suctioning, right? If your patient starts to choke, if they're vomiting, if they have extra secretions, if you're doing oral care, this is what you're going to need to have handy, all right? So this isn't like, you know, at the dentist office where your patient has to close their mouth to be able to suck out the secretions. This one, you can just put it in their mouth and it'll suck out the secretions wherever you put it, okay? Right? If your patient is not able to clear their own secretions, then this is what you're going to use. Okay? This is only for oral suctioning. Do not try to use this to suction somebody's nose, to suction somebody's trachea, or anything like this. This is only for oral use. Okay? And for tracheostomy, when you're suctioning, I don't know that we have a kit in our lab, but I'm there early in the morning, so I'm gonna look and see. I don't know, but it comes in its own little kit, and it'll say trach care kit on it, and it's got this is a sterile procedure. So remember, if you have to suction someone who has a tracheostomy, it is a sterile procedure to suction them. So this is where you would need to remember where to put on your sterile gloves and do all the things correctly. Okay. You should be or you will be responsible for making sure that the patient with a tracheostomy has a patent airway. All right. Your patient cannot breathe, their O2 sats will go down. They'll have a lot of difficulty getting those secretions out, and you will need to change the tracheostomy altogether or suction. Okay. Suction as often as need be. You'll notice some patients are super wet, meaning they have lots of secretions. Some people are a little bit drier and they need more humidification. But whenever your patient needs suction, suction them. And sometimes you'll notice if you're suctioning your patient with a tracheostomy that when you put the tube down, it's a thin little pliable silicone tube. When you put it into the trach, sometimes it will stimulate your patient to cough. And then they'll cough up whatever needs to come up, and you just suction it when they cough. All right? Do not suction for more than 10 seconds at a time if you are suctioning your patient's tracheostomy. All right? Because remember, that's going straight to their lungs. They can't breathe while you have something stuck in their trach. So you need to take it out, let them breathe, and then go from there. Okay? Certain situations, your unlicensed assistive personnel or their caregiver may be the ones doing the trach suctioning, all right? So like I said, this is how I learned. My patient taught me how to give him trach care. He taught me himself. Obviously, everybody can't do that. So you'll learn, and a lot of times if you're in a facility where there's a respiratory therapist, they will give you guidance on how to suction your patient. So if you're not sure, be sure to ask. Once again, it is a sterile technique. So make sure that you are making sure you know how to open your sterile field. Well, this one is really just open in the package, putting on the sterile gloves, and then everything else you need is already in there. You don't have to really open like we did in the lab before with the trach care kit. Okay. Right. Like I said, this part isn't for, I'm not here to teach you all things tracheostomy and all that jazz, because you will learn this, I believe, in med surg as well. So this may be part of our skills next semester, right? We just want to do the basics this semester. Okay. Oral pharyngeal, nasopharyngeal, and nasotracheal suctioning. Remember, the Yankauer is only for oral suction. See, there's a U in there, so that's why I call it a Yankauer. It's only for oral suctioning. So if your patient has, and I don't know how often they do this in the adult world, but we do it in Pediland all the time, where we have to use the small catheter that we use for tracheal suctioning. We use it for suctioning the nose. If we need to get further back than what a bulb syringe will get, then we will use the smaller syringe or the smaller catheter to suction. Okay. Remember, if you are doing trach suctioning, it is a sterile technique. See skill 14-5 in your book for any other guidance regarding that. And like I said, tomorrow I will show you guys. We have a super easy skill for tomorrow. It's just setting the oxygen flow meter. So since that one is so easy, then I can show you guys the other things, but you're not going to be graded or anything on the others. So if you want to see how to do the trach care and things like that, I can show you, but you're not going to be graded on it. So it'll just be FYI. Okay. Does anyone have any questions?
Ms. Duhan, are we going to be able to leave tomorrow as soon as we cover our skill?
Yes.
Or okay. Because my son has a doctor's appointment tomorrow.
Yes, that is fine. You can leave once your skill is completed.
Okay, thank you.
You're welcome. Any other questions?
Yes.
I was gonna ask if anybody wants to switch me for I'm in the afternoon tomorrow. Does anybody want to switch for the morning time? I don't have a car, remember? I broke down in Greens Point.